couple of minutes. And grand rounds, and thank those of you who are on time. Before I introduce our speaker, I have some housekeeping items. This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, which is a joint venture between the HMA and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone viewing grand rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find the evaluations by following the link in the chat at the end of this presentation or at any time on our website and email advertisement. Your comments are very important to the planning committee and will be used for future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Raman has disclosed that he has no relationship with commercial supporters that could be perceived as a conflict of interest for this presentation. It's my great pleasure to introduce our speaker for today, Dr. Arun Raman. He was appointed to the position of Associate Chief of Staff for the Geriatrics, Rehabilitation, and Extended Care Service line of the VA Pacific Islands Healthcare System in January 2021. He did his undergraduate studies at Morehouse College in Atlanta, then attended the University of the West Indies in Trinidad for medical school. He graduated in 1999 with honors in pharmacology and pathology. He then worked in the surgical departments and later the emergency departments in Trinidad for almost 6 years before joining the surgical residency program at Oregon Health and Science University in Portland. At his graduation ceremony, he was given a special recognition award for dedication to teaching of medical students during his chief resident year. He then worked on the Oregon coast, both clinically and in leadership roles, such as medical director, department chair, and chief of staff, with multiple awards from his hospital for service excellence and patient care. In 2018, he was awarded the Nizar Owida Scholarship by the American College of Surgeons at the Clinical Congress in Boston, in recognition for service and commitment to the rural community. He holds a fellowship from the American College of Surgeons, has a master's of business administration and healthcare management from OHSU. He obtained a certified physician executive credentials from the American Association for Physician Leadership and is a member of the American College of Healthcare Executives. So wow, those are a lot of wonderful credentials. It's my great pleasure to welcome Dr. Arun Raman. Dr. Raman, we're really looking forward to your presentation.
Hey, good afternoon, Dr. Masaki. Good afternoon to everyone here. I really appreciate you guys having me to talk about something that I think is particularly relevant across all age groups, but especially so in the geriatrics age group. So I always start with this photograph, or always end with this photograph, just to remind myself that I need to get out and do more exercise, because only my friends drag me hiking up Lanikai Pillbox. But I didn't want to start with the name of the presentation because we had some changes along the way. A year ago, 9 months ago, when I spoke to Dr. Masaki about doing the presentation, I started off with the tentative title of Abdominal Pain in Older Adults. And I thought about it for a while, and I realized that you could spend 3 months with me on a residency, full-time residency, and it would take probably that amount of time to understand abdominal pain in older adults and all of the differentials that you would really need to appreciate. So I thought about it, I scratched my head a little bit, and I said, okay, why don't we just narrow it down a little bit and talk about right lower quadrant pains in older adults. And when I thought about that, I really started to think about all of the times that I've had to see patients in the last 20 plus years where either there was, for want of a better word, I'll say misdiagnoses, either overconfidence in making a diagnosis or a failure to consider differentials for some stuff. So, I kind of narrowed down it a little bit more again. So what I'm going to be talking about today is going to be specifically right lower quadrant pains in adults. So I'm going to talk about adults broadly with some focus on geriatrics, but I really want to take it back to the basics. And even though this is going to be something that everyone should be able to digest, there's going to be a little bit of emphasis for the residents and the med students with some questions that tend to pop up. I'm not going to call on anyone. I'm not going to pick anyone out of a group to ask questions, but there are things that I'm going to mention along the way in terms of the questions that are asked in the slides that I'll answer by myself that the residents and medical students sometimes will get asked about when they're on their rotations. But I think it's a basic enough but important enough set of topics that even someone who's been in clinical practice for many years would appreciate as a refresher, because there are things that I see happening clinically with some of these diagnoses that might not lead to the best care possible. And I'll explain as I go along. So we'll talk about right lower quadrant pain in adults. I have no financial disclosures, as Dr. Masaki mentioned. And I'll start with, it's always good to start with the case presentation. I'll start with one of the very first patients I ever saw as a junior medical student. And I changed a little thing on this, but I remember walking down the hall, seeing this gentleman across the hall in the room on a gurney, and being told, "Hey, Arun, I want you to go see this patient. He's had a day of right lower quadrant pains." And as I see him in the distance and I'm walking to him, I distinctly, recall him holding his right lower abdomen, lying in fetal position on his side, looking uncomfortable. And that just strikes a mental image as you move forward. So first thoughts, and I'm going to throw it just out there for no one specific to answer, but what are your first thoughts when you hear that and when you see that? Obviously, as we've been programmed, the first thing you think about is appendicitis. A little history on appendicitis. It's actually really interesting to go back 120 years, 130 years. The surgeon the physician, the Bostonian physician that first mentioned appendicitis was somebody by the name of Reginald Fitz, Dr. Fitz. No relation to Fitzhugh as part of the Fitzhugh-Curtis syndrome. And if you remember, Fitzhugh-Curtis syndrome is a perihepatitis that happens with PID. I'm sorry that I didn't put a photograph up of Fitzhugh-Curtis syndrome, because it's really just incredible looking from a laparoscopic point of view. It's almost like Spider-Man dropped webs down on the liver and it's just kind of suspended by these things. But so no relation to that from Fitzhugh-Curtis syndrome. But Reginald Fitz from Boston first mentioned appendicitis, and then everybody knows McBurney. McBurney came along a couple years later and published his multiple seminal papers on appendicitis. And it's interesting to note that in 1886 or 1890 or whenever it was that McBurney was publishing these papers, the mortality for appendicitis was 25%. One in four people who had appendicitis died of appendicitis. At this point, it's about 1 in 1,000, and we honestly could do better. It should be lower. But again, part of the issues that we have is either misdiagnosis, late diagnosis, or diagnosis in susceptible populations, such as the elderly, which obviously lead to major complications, morbidity, and even death. And it still remains the most common abdominal surgical emergency in the world. So, let's again go back to basics and start asking, what is it that we need to make a proper diagnosis of appendicitis? Because I've seen, as I said, many people go, "Oh, right lower quadrant pain, it's got to be appendicitis," and completely miss the differentials. And then in the older populations, I have seen the exact opposite, where somebody has vague abdominal pains, an atypical presentation, which is what you expect to see in the older population, and completely disregard or ignore appendicitis, which is known as the great mimicker. Ignore it because there's other things that they're thinking about. Now, and I talked about this a little bit the last time I presented for you guys. And I said this jokingly, but I said it seriously as well. I have high regard for specialists in the internal medicine field, because I remember very distinctly, in my training, being on my internal medicine rotations and being asked, what are the 20 differentials of upper GI bleed? And you have to get to 18, 19, and 20. You have to get to blue rubber bleb syndrome and chicken neck syndrome, or xanthoma elasticum, I think is the appropriate name. Whereas with surgeons, we're really simple. We just want two diagnoses, two differentials for upper GI bleed that we want to talk about, at gastritis and duodenal ulcers. But I had to have a way to break it down in my head in terms of how I was going to handle any question that anyone threw at me. So, so for abdominal pains, I thought it was pretty easy to in my head break it down in terms of male versus female. The other thing that was very helpful is, in any differential, most serious to least serious. So, for example, chest pain. When you think about chest pain, you want to think about dissecting aortic aneurysms and myocardial infarctions as the most serious. But if someone were to ask you the most common causes of chest pain, clearly you want to start with musculoskeletal and chronic cough as the most likely. Or anatomically, if someone's asking causes of hematuria, it was easy for me in my head to go, okay, let's talk about urethra, then bladder, then ureters, then kidney, and then kind of break it down from that perspective. So whatever algorithm you have as a resident or a medical student, please use those as means for your differentials. For right lower quadrant pain, I'm going to break it up in terms of gender, but also in terms of seriousness. So as a whole, for all adults, including individuals of childbearing age, the first things that I want to think about are obviously the urgent ones, ectopic pregnancies, and then what I call the accidents of ovarian cysts. So if someone has a torsion of a cyst, then clearly that's kind of an emergency that requires intervention sooner than later. And then there are the things that are less likely to be dramatic emergencies in that moment. Pelvic inflammatory disease, which I know the geriatric population has had an increase in the last 20 years. But again, for the patients of childbearing age, do not forget about Mittelschmerz, endometriosis, and other ovarian type presentations. And then when I thought about male and female type differentials, again, if you divide it up into urgent ones, appendicitis, the great mimicker, because it's going to look like a lot of these differentials. Colon cancer on the right side. And then this is another important one for the geriatrics population, diverticulitis. Don't forget diverticulitis. I know we think about diverticulitis being most common in the sigmoid area, especially in the older patient, and that's absolutely true. But I don't know if you all have the ability to look at every single CT scan that comes your way instead of just reading the reports. But if you get into the habit of looking at a lot of CT scans, you'll see how much redundant sigmoid a lot of people have, and how much that floats over to the right side. So right-sided pain can be caused by left-sided or sigmoid diverticulitis as well. So don't be thrown off by that, when someone presents with right-sided pain. And then we run through the things that I love to kind of talk about in terms of differentials. I'm not going to speak about every single one here, but the two that I like to jokingly talk about for a couple minutes are the Meckel's diverticulitis, which everybody learns about the rules of twos when you're a medical student. 2 feet from the ileocecal valve, 2 inches in size, and 2% of the population. You learn the rules of twos along the way, but it is something that is commonly seen in adults, especially intraoperatively or on CT scan for investigation and workup for abdominal pain. So don't forget that Meckel's can happen you can see an undiagnosed Meckel's in an adult, and the presentation can be a severe abdominal pain all of a sudden in someone's 40s, 50s, 60s, or 70s. And the other one that I think very humorously about is epiploic appendigitis. I will tell you, I've seen at least 3 ER physicians call the radiology department to tell them that there's been a typo in the report because they spelled appendicitis wrong. And I can visually imagine the technician on the phone, or even the radiologist on the phone, just holding their head and shaking their head a little bit. Epiploic appendicitis it's not seen very often, but every once in a while, and probably once in your career, you'll come across it where the epiploicae on the cecum actually gets inflamed. It is not a surgical condition. It is horrific pain, horrific right lower quadrant pain that will mimic appendicitis, but it's just NSAIDs, reassurance, and home, and the pain eventually goes away. It is not a surgical condition. So make sure you have that at the back of your head. At some point, you might pull it out in 10 years and refer to it when you see a CT scan. So we'll talk about these differentials a little bit more, but I do want to stop and spend a minute on the colon cancer differential. When you go back and you look at your statistics, for men, it's the third most common cause of cancer. You've got lung cancer, prostate cancer, colon cancer. And for women, it's the third most common type of cancer. You've got, again, lung cancer, breast cancer, and colon cancer. So combined for men and women, it is the number 2 cancer in the US. And every single time you have abdominal pain in a patient, especially an older patient that you don't immediately have an easy diagnosis, excuse me, for, please do not forget to rule out your colon cancer diagnosis. Always ask the question, what is this patient's family history? If they have a parent with colon cancer, it's going to double their lifetime risk. If they have 2 parents, it's going to quadruple their lifetime risk. If they haven't had their colonoscopies, then obviously that increases your suspicion as well. I have seen many a case of colon cancer missed, and I'll tell you, I had a friend when we were 30 years old that I diagnosed with stage 4 colon cancer. So we're seeing younger and younger cases of colon cancer, and as we have patients live longer and longer, we're going to see older patients with colon cancer as well. So that's my plug for colon cancer. We'll come back to colon cancer a little bit as well in terms of some of the management items that gets missed. So please don't forget that in your differentials. The types of appendicitis that you will encounter is important for this group, not because I need you to understand how to manage each group of appendicitis. Acute appendicitis, also called simple appendicitis, versus ruptured appendicitis versus an abscess. I don't want you guys walking away from here thinking that you need to know how to manage the 3. What you need to know is basic aspects of the management, because especially in the geriatric population, this is going to severely affect their morbidity and mortality. So just kind of knowing the basics of the algorithm that surgeons would use is really helpful, I think, if you're managing any adult patient, but especially patients in the geriatric population. So I'm gonna briefly talk about the 3 different types of appendicitis I want you to be aware of, and how the management strategies change a little bit. But we'll also talk about how we get to the diagnosis as well. So really basic stuff. Classic appendicitis, periumbilical, going to the right lower quadrant. And the question that every so often that gets thrown out there is, why does it start by the umbilicus and go to the right lower quadrant? Because that double layer garbage bag that we have called the peritoneal lining gets irritated in 2 separate stages. The visceral peritoneum causes that periumbilical, centrally radiating pain. And then when it gets worse, the parietal peritoneum gets irritated, and that causes it to be more localized. So that's classic. You'll hear about that all the time. But the part that's important in starting your history, starting the questions for your differentials, is what other symptoms are present, and what is statistically the most common symptom, the most consistent symptom besides pain. Pause for a second. I'm hoping that all of you all know this, but it's anorexia. I have, I think, twice in the last 20 years seen someone present with obvious appendicitis and still say, yeah, I'd like to eat. Anorexia is really the important one. If someone is if someone's hungry, they're actually hungry, I really want you to spend the time to ask the questions about the other differentials before you make a diagnosis of appendicitis. You know, when I was in training as a medical student, we talked about fever and diarrhea and dysuria and all these other things. Anecdotally, I will tell you, I have hardly ever seen that in a presentation with appendicitis. The time that you're going to spend with your questions are going to be on your pertinent negatives. And we talked about those differentials in those slides a couple slides ago. This is a standard list of questions that I ask for any adult who presents with abdominal pain, especially if it's lower abdominal pains or right quadrant abdominal pains. Have you eaten any food from outside recently? Did any of your family members eat the same food as anyone else sick? Quickly, you can identify a cluster of gastroenteritis. The IBD question. I remember having a patient who was referred to me. The ER doc called and said, "Oh, this is classic appendicitis. Classic appendicitis." And I just remember kind of smiling when I got the phone call, and I went down. It was a pleasant, young adult female with her mom, and her mom happened to be an ICU nurse, and their questions were more along the lines of, okay, appendicitis, when do we take it out? And I said, no, well, let's talk a little bit. And the first set of questions I asked was, have you ever had these kinds of pains before in the past? And she said, yeah, I get it every so often, every month, every couple of months. And her mom was shocked. And I said, well, do you have any bloody or mucousy, slimy stools? And she said, oh yeah, absolutely. This has been going on for a year or two or whatever it is that she said. So we went very quickly from moving down a direction of potential appendicitis to is this inflammatory bowel disease. And her mom was obviously aware of the questions and the line, the line of questioning that I had for her, but was very surprised by her answers. So in the older population, you can still see inflammatory bowel disease. Please don't hesitate to ask the questions, but the frequency of whether or not this is the first time that the pains happened is a critical question. Hematuria, dysuria for cystitis, UTIs, that's pretty straightforward. That's your bread and butter. You guys deal with this way more often than most people. Mesenteric adenitis, have you had a recent viral infection? And then PID, obviously the sexual history or the history of vaginal discharge or urethral discharge is important. The physical exam. I feel like the art of a physical history and physical exam is not what it used to be. And again, I think every generation of physicians says this, but walking up to the patient, you should have a group of differentials in your head, and talking about their position in bed, how they lie in bed, how they're holding their pain is very critical. I'll give you a classic example, renal colic. I typically will see patients with renal colic doing what I call the kidney stone dance. They're usually standing up and they're wiggling about and they're kind of like dancing to some cool 50s music. Usually they can't lie down and hold still. They have to wiggle about and move for kidney stones. The other thing that they do is if you imagine, I'm not going to do it and put the camera on me, but if you imagine how Superman stands or Supergirl stands, hands on the hips so that your thumb is touching your lower back and your index fingers pointing down to your groin, that loin to groin pain, if they say that pain is coming from the back and going around, going down, as opposed to just being fixated in the right lower quadrant, that tells me more of, kidney stone, ureteric type pains. And then with the abdominal exam, you're looking for your 4 signs of peritonitis, tenderness, guarding, rebound, rigidity, obviously. And as appendicitis progresses, as it goes from acute appendicitis or simple appendicitis to perforated appendicitis to an abscess, you're going to see variations or increasing numbers of those 4 signs of peritonitis. Little point here with rebound. Actually, I'll mention it when we talk about Robsing sign. So McBurney's point. McBurney, as I said, he had some really great papers, But his paper, the seminal paper that everyone refers to, I think he only had 18 subjects, so his N was really small by any standard. It's good to just know where McBurney's point is. It's a 2/3, 1/3 breakdown, and it's always easy to remember because you think about the appendix lower down in the pelvis, so it's got to be 2/3 from the umbilicus to the ASIS. So that's how you kind of remember where it is. But the funny thing is, even though you know that that's kind of generally where it is and for historical purposes, with an N of 18, you don't expect it to be accurate. And I've seen actually one paper that talked about the fact that if you did a barium enema on every single patient that you see with appendicitis, it's like 1% of the time it's actually located there. There's so many variations for where it is. But the location of the appendix is critical for your physical exam. So regardless of the fact that McBurney may not have been completely correct, the basic anatomy is actually important for, excuse me, for your clinical exam. When we talk about psoas signs, we'll talk about the classic 3 signs of appendicitis. This is where I get a little confused with American medical textbooks versus British medical textbooks. I was always taught decreased pain with flexion of the hips and knees. I think I've seen some American textbooks refer to psoas sign as eliciting pain by extending the hips and the knees and extending the knees. I don't think you need to hurt the patient when you check for psoas sign. You just have to ask them the opposite. Hey, can you bend your hips and knees? Can you get into a little bit of a fetal position? Does that help? Does that alleviate the pain? So it's gentler and it's kinder. And what that does is when you flex the hips and you flex the knees, it lifts the appendix up off the psoas muscle, so it irritates it less. And that's why it's called a psoas sign. Robsing sign, that's when you palpate on the left side and they get pain on the right side. You will see this with anything with a peritonitis, with peritonitis. So it doesn't have to be with appendicitis, but you will see rebound and Robson's with anything that causes peritonitis on the right side, not just appendicitis. And the reason is it's peritoneal irritation. The peritoneal sac is very pain sensitive. It's like the periosteum and bones. So when you're checking for rebound, for example, I'm going to go back to rebound. I see a lot of people push really hard and let go really fast. And you don't have to do that when you're checking for rebound, nor do you have to do that for Robsing sign. What I would typically do for checking for rebound or for Robsing is I'll warn the patient, I'll say, hey, I'm going to push on you a little bit. I know this is going to hurt, but bear with me. And I'll very, very gently, slowly compress their abdomen, very gently and very slowly, and say, hey, it's going to hurt you for a few seconds. Give me 5 seconds. And I'll talk to them. I'll distract them. I'll say, I'm hurting you. I know it's hurting a little bit. I'm going to let go. Before I let go, I'm going to tell you, and I want you to think before you answer, is it hurting more when I press or more when I let go? Give them a little awareness. And then I gently let go. You don't have to let go super fast because that jerking is painful as well. It doesn't have to be as aggressive as you see a lot of people do it. And then let them think before they answer the question, because sometimes it's a hard question in terms of hurting more, hurting less. So with your rebound, be gentle. With your Robsings, let them know what you're looking for as well. And then the last one, which is more academic than not, is pain on passive internal rotation of the flexed hip, and that's stretching and irritating the obturator internus when that inflamed appendix is touching that or sitting there. So you will hear about an obturator sign. Not everyone checks for it. By the time you've gotten through most of the physical exam, you kind of already know where your differentials are. This is where I think a lot of people make mistakes. It's the presentation of the physical exam, the clinical suspicion, and then you get a white count, and the white count's normal. And you go, oh, and I've seen physicians do this and go, oh, the white count's normal. It's probably not appendicitis. It might be something else. I think it's quite acceptable to say up to 10% of people have a normal white cell count. I have seen papers that say up to 20% of people will have a normal white cell count with appendicitis. The level of the white count is not corresponsive to whether or not the appendix is perforated or not. So I don't want you to think that if you have a white count of 15, that means it's more likely to be perforated versus a white count of 10.5. So, and I'll repeat that. A white cell count that's elevated is helpful. A white cell count that's not elevated does not rule out appendicitis. And the level at which the white count is at is not indicative if the appendix is gangrenous or perforated. So don't make an assumption based on that. And I've seen people fall into that trap. CT scans. Historically, so when I was a medical student, and again, I'm making it sound like this was 100 years ago, but when I was a medical student, we were told that a 20% negative laparotomy rate was good. You know, hey, if you make a diagnosis and you go in and about 1 in 5 times it's not appendicitis, that's perfect. Because if you're finding a higher rate of normal appendixes, then you're operating on too many people. Or if you find a lower rate, then you're letting some sick people with appendicitis perf out on the unit. So we were told aim for about 20%. The number is probably less than 6% now, and that's a good thing. It's actually more cost effective and safer to use imaging when there is a doubt for the presentation, especially in the geriatrics population where there's an atypical presentation. So one of the things I want you to walk away from with this discussion today is have a low threshold for some form of imaging if you're not 100% sure it's appendicitis. If you're not classically sure that this is an obvious case of appendicitis, which again, it's the great mimicker, and I'm kind of making that tongue in cheek. If you think it's appendicitis, imaging is probably something best to do. So I was always taught the gold standard in appendicitis of management of appendicitis is appendectomy. And that's not exactly true anymore. We'll talk about non-operative management in the next slide. And the other thing that we were taught when I was in training is, yeah, we think laparoscopy is almost as good as open incisions. We actually do laparoscopies as a standard of care right now. The thought process before, just for your awareness, is, you know, when surgeons started doing these laparoscopically, we stuck the camera in and we saw a little bit of pus. We saw like 3 cc's of pus, which was like, oh my gosh, there's so much pus. And we would irrigate with 1 liter or 2 liters of fluid, of saline. And we thought we were doing good. And what we were doing was just spreading pus all around the belly. And we were creating intra-abdominal abscesses. So initially that was what was going on. Now we don't, now we don't do that at all anymore. We just go in, take the appendix out, and kind of just suck up whatever pus. It's better for length of stay. It's better for pain use, narcotic use. It's better for complicated patients where you don't know for sure that that's the diagnosis. You do have to be careful in the geriatric population, especially for severe cardiac or respiratory comorbidities. With the insufflation of the abdomen with carbon dioxide, you are putting about 16 millimeters of pressure on the abdomen and on the inferior vena cava, and that obviously reduces your cardiac return. So if you have patients who are serious cardiac risks, then obviously your anesthesia provider is going to assess them and let you know. So, but you can do laparoscopy in the geriatric population, and many times that's what we prefer to do. This is a little table that I used to use in terms of how to, again, in my head, figure out what my algorithm is. So if it's a low suspicion for appendicitis, you can watch them for a day. As long as you have someone touch their belly every 4 hours and you monitor their vitals and you keep a really close eye on them. So if for some reason you can't get a patient to the ER, you can't get the patient to a surgeon, but this happens to be someone that you're able to see very closely over the next 12 hours or 24 hours, and you're touching their belly every 4 hours, that's okay. Because if you're not sure and it's really early, almost always they will gradually get worse. They're not going to get better within 4 hours. They're not all of a sudden going to have severe pain that just immediately goes away. That's extraordinarily unlikely. So for low suspicion, yeah, you can do that if you want. But high suspicion, obviously, going to call for your consult. You're going to have that patient end up having an operation or have non-operative management for whatever reason. Most of the times, you're not going to know. Most of the times, you're going to think it's appendicitis. And that's when, as I said before, have a low threshold for imaging. Either do an ultrasound, a CT, or if it's a pregnant patient, if you're dealing with someone who's not in the geriatric age group and is in a fertile age group, please consider an MRI for a pregnant patient. So antibiotics. Wow, very controversial. When I was in med school and in residency, what I was taught was non-operative management of acute appendicitis with antibiotic therapy alone was associated with high rates of clinical failure recurrences. We were told if you have appendicitis and you take out the appendix, you've cured the patient. But if 85% of patients who get antibiotics only resolve and 15% don't, and 15% have a recurrence later on out of the 85, either way, then really are you helping them? What I will say is antibiotics for the treatment of acute appendicitis is a valid and a useful mode of therapy, especially if you have complicated patient. And again, the patients that you will see in the geriatric population is going to clearly have multiple comorbidities, complex patients. You're going to see a lot of that, more so than other specialties. So you are going to see, if you haven't already, you're going to see a lot of surgeons start leaning into non-operative management with antibiotics alone. We talked about colon cancer earlier. One thing that I want you to be a line of defense for your patient and advocate for your patient is if you happen to have a patient that goes to the hospital, gets non-operative management for appendicitis, resolves and goes home, please make sure that they're having their colonic screenings done. You want to make sure that you're not missing something else. And then this is another algorithm that I think is helpful for the non-operative management aspect of acute appendicitis. One of the biggest factors that determine if it fails, if antibiotics only is going to fail, is the presence of a fecalith on the CAT scan. So you have your patient, not sure if it's appendicitis, you get your CAT scan, excuse me, and then you send the patient for the consultation. If you have already seen the results and there's a fecalith within the lumen of the appendix, then you already know that that patient is probably not going to do well on antibiotics alone and will likely need an operation. So let's talk about the algorithm that they put here in this UpToDate. And I apologize, I didn't have the reference put in, but this is from UpToDate. If it's not perforated, if it's simple appendicitis, if it's a stable patient, because if they're not stable, you need source control, you have to operate. You should operate, with caveats, obviously. But if they're stable, and if they don't have a fecalith, then absolutely, you can talk to your patient about non-operative management. And this is useful, again, if you're primary on a 80-year-old patient who may not get to the surgeon for 8 hours, 2 hours for transport and then 4 hours in the ER and whatever the case may be, have a low threshold to start antibiotics as well. As long as you're covering for your anaerobes as well. Don't people? I see people forgetting the flagell. So your antibiotic options are up there. But if you think that there's going to be a delay in getting to a specialist, have a low threshold for your CAT scan. Have a low threshold for starting antibiotics. One more thing that I'll mention about imaging and for CAT scans specifically. Oh, that I'll come back to that. That the thought just completely skipped my mind, but I'll come back to it probably. So we talked about uncomplicated appendicitis. We talked about management of uncomplicated appendicitis. Oh, I remember what I was going to say about CT scans. My apologies. So it's interesting to think about CT scans for a second with respect to appendicitis. There are multiple protocols that you can do for an abdominal exam. You can order a CT with, for example, IV and oral contrast. And I will tell you, as a specialist, as somebody who deals with abdominal conditions, I love the IV and oral contrast option. It will not only tell me what I'm looking for, it'll tell me other things that's going on, and it will help me in a blueprint for operative intervention. It will tell me, is there anything I need to be aware of, and where I'm putting my ports and incision, and like, is there something that's going on that I should be aware of? So I will love to order an IV and oral contrast. So if you give someone gastrographin to drink, they've got to sit in the radiology department for 2 hours for that CT scan. So a lot of times in the ER, they will just do IV only, which is fine. The detection of appendicitis with IV contrast only is extremely high. It's an ideal test. It's an easy to do test that doesn't require waiting. But many times you're going to have patients that have compromised renal function, and you don't want to be giving them contrast loads frequently. So the ER docs along the way, I think of 10, 15, no, probably about 15 years ago, did a bunch of studies that they really wanted to dispo the patients and get them out of the ER. So they looked at non-contrast CTs in terms of their sensitivity for finding appendicitis. And guess what? It is actually pretty sensitive for identifying appendicitis. So if you're looking for appendicitis and you're going to order a CT scan, the rule that I would advise you in your geriatric population is, if you have no clue what's going on, if you're really confused and stumped and you think it might be appendicitis, but there's a bunch of other stuff going on, and you want to take a look at the small bowel and you want to check for hernias, and there's just a lot on your differentials, IV and oral would be ideal. If you feel pretty sure it's appendicitis, IV contrast only would be perfect. That's your safe bet. But if you have a patient with renal compromise and you're worried that you really want to avoid a load, at least a contrast load, at least get the non-contrast CT. It's going to be still useful in the diagnosis for appendicitis. So that's my little plug when it comes to CT scans. So we talked about uncomplicated. Very, very quickly, for perforated appendicitis, it is found in a significant number of people, up to 20%. It's higher in men and it's higher in older adults. Generally speaking, if they're sick, we're taking them to the OR to take out the appendix, because obviously we want source control. But we can also treat them with antibiotics and come back in 6 to 8 weeks and take out their appendix, especially if they're medically complicated. Because I want you to have this image where, with uncomplicated appendicitis, think of a gummy worm. I mean, most of us have eaten a gummy worm at some point. You just pick it up and you snip it off and staple it and tie it off and you pull it out. Once it becomes perforated, imagine someone pours glue in there, and imagine the gummy worm turns into crumbly cheese. So picking up the appendix snaps it in multiple places, stool leaks everywhere. Once it's a micro or macro perforation of the appendix, you probably have like a 40% risk of a pelvic abscess. So antibiotics, let them heal, let the inflammation go away, and then you get your clear demarcated lines. We go back and we take it out. So antibiotics you're going to see a lot of antibiotic use in this group. And then for the abscess group, again, if you have a really sick patient, we may have to intervene. But if they're relatively stable, we'll stick a drain in it. We'll call the radiologist. We'll have them stick a drain in it, drain it, put them on antibiotics, and then decide if we want to operate on them at a later date. One of the things that we really focus on with the non-operative route is the medical complexity of the patient. And I'll take a second just to explain this. If I'm dealing with an older patient and he's a 70-year-old man on aspirin, Plavix, and warfarin, and I'm old school, so I'm going to say warfarin. I know you guys use a lot of the newer agents now. and he's got a ejection fraction of 27. And he was he's had jaw surgery and neck surgery, so he's a difficult intubation. That's definitely going to be the patient that I'm going to try, even though I know that it's only going to work in 85% of the patients. Excuse me. For that acute appendicitis, that's the patient I'm going to put on antibiotics and try them for. Once you get to perforated appendicitis and abscesses, more often than not, you're going to lean into antibiotics anyway and try a non-operative route. But even in the acute appendicitis group, where the dictum was, when in doubt, take it out, you will see us, especially in the geriatrics population, lean more and more and more as data comes out saying this is a safe thing to do in the absence of a fecalith, if they're stable, and if they're medically complex, especially, you can use non-operative management and let them go home when they resolve. There is a 15% recurrence rate, though, so just be aware of that. So how do we summarize some of the issues with the elderly and appendicitis? 1 in 2,000 adults over 65 will develop appendicitis annually. Older patients will have less subjective pain, decreased findings on clinical examination, delayed leukocytosis. We talked about that being, I've seen that being an Achilles heel in a lot of physicians' diagnoses. Delayed medical care, and as a result of all of those things, plus the medical complexities, have a higher rate of perforation. So remember, low threshold for CT imaging for those patients. And I'm going to throw this in, even though that this is a geriatrics group. Along the way in your career, you might be able to save a fetal life. So I'm going to have a plug for the pregnant patient. Appendicitis is still the most frequent non-obstetric indication for laparotomy during pregnancy. A perforated appendix is associated with a high fetal mortality rate of greater than 30%. And even simple acute appendicitis has a fetal loss in the range of about 10%. So we can do laparoscopy in all trimesters. It's a little bit more difficult, obviously, in the 3rd trimester, but it can be done, or we could do it open. But the risk of a delayed diagnosis results in a high risk of fetal mortality. So if ever you're in a room with someone making a decision for a pregnant patient, please emphasize the need for a rapid diagnosis and rapid intervention. And the last thing I can mention about pregnancy and appendicitis is you can do ultrasounds, which are so-so, but MRIs are really the gold standard. And that's the one case of appendicitis, the one type of appendicitis that I would strongly advocate for the use of an MRI for the diagnosis. So that's it for appendicitis. The last 2 minutes, I'm just going to quickly talk about a really interesting case. I know some people may know about this, excuse me, but you can actually Google it and read the diary of this Russian surgeon who was out in the Antarctic in, I think it was 1960. Yep, 1960, with his group, out to sail. No one else had any medical experience. Fell ill, tried antibiotics, tried a bunch of stuff, didn't tell anyone because he was like, oh my gosh, I've got appendicitis. No one here can do anything. I think I'm going to die. And after realizing that nothing was working and he was getting sicker, he decided that he was going to have to operate on himself. So he told his crew, he sat in a semi-reclining position, needed to feel the inside, so didn't use any gloves, but he sterilized and anesthetized the area, was local, stuck his fingers in after making a 10 centimeter to 12 centimeter incision, pulled his appendix out after an hour and 45 minutes, managed to get it out, close it up. His diary is extremely interesting because he talks about how everything was gurgling and how he almost passed out a couple times, and how the two crew members who obviously had no medical training who were trying to assist him also like turned ghost white at several points in time. So, the point being that, even someone, it's not a difficult procedure. It's not a complicated procedure. You can do it on yourself. Apparently, this is not the first and last time that it's been done. There's other cases of this, but it is something that is a great mimicker. And if you don't ask your questions from your negative, the negative pertinence, and you don't do a proper physical exam, you don't do the imaging, especially in the geriatric population, you're going to end up with something bad happening. So that's it for me. I'm 10 minutes ahead. Unlike last time, I didn't run over. So I'm going to hand back to you, Dr. Masaki, and I'm happy to take any questions about appendicitis or anything abdominal pain related in the populations that you guys see. Thanks a lot. Appreciate it.
Thank you so much, Dr. Raman. Wow. I think that guy, I would have definitely passed out very early on in the process, I think. I've never heard of anybody removing their own appendix. That's really mind-boggling.
If there weren't photographs of it, I wouldn't believe it myself.
Yeah. I don't know, that guy must be very stoic. Anyway, thank you so much for a very interesting presentation, very useful information. For our audience, please type your questions in the chat box, or if you would like, you can unmute yourself and ask the question directly. Dr. Raman, while we're waiting for the questions, I just remembered a case that I had many years ago when I was young faculty. And I remember I was a little surprised at the atypical presentation, but there was a patient who actually ended up having a ruptured cecum and did not have free air under the diaphragm on X-ray and did not have peritoneal signs. And I remember, unfortunately, the patient looked sick. And so we went ahead with more investigations and a CT and got a surgical consult. This patient did get taken to surgery early. But I remember being so surprised at complete lack of some of those signs in an older patient.
So, air under the diaphragm is, you have to have a fair amount of air to see air under the diaphragm. So we talk about it as, as a sign of a free, as a perforation of of viscous. But there are a couple of things with it. Number one is you do have to have a sizable amount of air. And two, you get your best imaging from the patient sitting up. So if you have an older patient who's maybe a frail patient or a sick patient and you're doing supine films, you may not be able to appreciate, unless you do a lateral, then maybe you might see the air, but still it's going to be very difficult. So and I'll say the same thing for if you have a geriatric patient that falls and breaks a few ribs, and along the way someone's done an X-ray to check for a pneumothorax. It's very easy to miss a pneumothorax. If you have a clinical suspicion, CT for the abdomen for free air and CT of the chest for broken ribs and a pneumothorax, extremely sensitive. I have seen, I can't even tell you how many. I would say a significant percentage of 70, 80, 90-year-olds with broken ribs that have normal X-rays for pneumothoraces, but end up having a pneumothorax diagnosis on CT. So absolutely, when you have that gestalt, when you have that little tinkling, that spider sense that something's not right, especially if you're thinking abdominal, that CT with IV contrast, or even if you have to, just a non-contrast CT is not a bad idea.
Sounds good. Does anybody else have any questions? Michaela, could you put the evaluation link? Oh, there it is. She anticipated me. So the evaluation link is for CME purposes, and Michaela just put it in the chat box. We'll stay on, if it's okay, Dr. Raman, we'll stay on for a couple of minutes, just in case people still have questions, but haven't had a chance to type them in. So we'll give them a minute or two. But thank you again
Absolutely.
for a very useful presentation. We often have patients who present with abdominal pain, and sometimes the diagnosis can be quite tricky. And often the patients may present with very atypical signs. So it was very useful to hear some of the little tricks that you gave us.
And I also, I want to say it, even for the third time, I think there's a little bit of overconfidence with the diagnosis of appendicitis. I think there's a lot of physicians who go, well, oh, that's like the first thing I learned in medical school. I know how to diagnose appendicitis, but it's a great mimicker. It is a tricky, I will tell you, even surgeons have difficulty with the diagnosis of appendicitis. So if it's not something that you're seeing frequently, it can be a little tricky. And then the other plug, I'll say it again for the third time, colon cancer. Your population is so susceptible, and especially in rural areas, especially in places where they may not have had their screenings done. And just remember, when you're doing a CAT scan, CAT scans are not going to necessarily show colon cancer. It's not going to show anything intraluminal clearly, unless you have extension outside, or you have some haziness, or you have some Mets. So don't exclude a diagnosis of colon cancer if you have a normal CT. You always have to have that in the back of your head. Yes, screenings are between 45, and now it dropped to 45 right a few years ago. But 45 to 75 is really where we do our screenings. And I know you guys take care of patients that might cross that age group, but always asking when that last colonoscopy was done, or the last screening, even if it wasn't a colonoscopy, and the family history, because that multiplies their risk in my head. If I know of a family history of colon cancer and they suddenly present with constipation and abdominal pain, which is classic. You guys see that, like, how many times a week you guys see that, right? Constipation, abdominal pain in the older patient. The first thing that I get palpitations about is this undiagnosed colon cancer.
Right. Okay, well, I don't see any questions. So again, I wanted to thank you, Dr. Raman, for an excellent presentation. We would love to invite you to come back again to talk about another surgical trick at some point. And thank you to our audience for your attention.
Thanks, everyone. Appreciate it. Have a good day.
Bye-bye.